We are in a very interesting framework in breast cancer and in oncology at large, where we have to ensure that we are able to provide effective therapies. At the same time, the cost associated with these treatments is quite substantial. And in order for us to be able to incorporate innovation, in order for us to incorporate new therapies, we need to make sure that we also transition some of our old biologics and incorporate biosimilars. The European bodies have done this tremendously well since 2006 through EMEA recommendations and EU approvals for biosimilars. And I think in many ways FDA and Health Canada are now looking at this through the same lens, but at a later date. We do need biosimilars in order to help drive down the costs of biologics. And in breast cancer, one of the drugs is trastuzumab, which is one of our key costs associated with treatments associated with breast cancer, and hence there's a rationale to look at biosimilars for trastuzumab. When we take a look at biosimilars, it's very important to acknowledge that these are not generics. These are biological entities that require a very complex mechanism of manufacturing, and also a complex framework for us to assess whether they truly are biosimilar or similar in biological principles. So our healthcare regulatory bodies have a different assessment looking at different quality attributes to assess, is there biosimilarity, at least from a manufacturing, from a product perspective. From a clinical perspective and from a research perspective, when we evaluate biosimilars, the endpoints that are used are different than when we evaluate new innovators in this setting. So there is an interest to look at different endpoints such as response rates in metastatic setting, and even looking at PCR in the neoadjuvant setting when we're looking at biosimilars.